Hi, good morning, everyone. Thank you for joining us. So we're going to quickly get started. The Rutgers School of Public Health, along with its Center for Public Health Workforce Development, which is part of the Region 2 Public Health Training Center, has brought together leaders and practitioners exactly 1 year and 1 day since the World Health Organization declared COVID-19 a pandemic to discuss what's next for the field of public health. Good morning, everyone. Before we begin, we want to observe a moment of silence to remember more than 530,000 Americans and more than 2.5 million people worldwide who have lost their life to COVID-19 in the last year alone. Thank you. The individuals who join us today have been involved with ending the COVID-19 pandemic and will provide valuable insight on what is our next big focus to ensure the health and well-being of people and populations in New Jersey, across the country, and around the world. We, as moderators, will be asking our panelists a series of pre-selected questions. We encourage you to place any questions that you may have during the event in the chat box, which we will try to get to during the Q&A portion of the event. Now to introduce the moderators, we have Brenda Flanagan, who is Senior Correspondent for NJ Spotlight News. Her reporting focuses on COVID-19, transportation, environmental, and immigration issues. The Emmy Award-winning reporter has also worked as an investigative and political correspondent for several news departments. Dr. Perian Halkitis is Dean of the Rutgers School of Public Health and Director for the Center for Health Identity, Behavior, and Prevention Studies. He has been actively involved in many aspects of New Jersey's COVID-19 response, including being a trusted source of information on the virus. His center, CHIPS, has been actively investigating how COVID-19 has impacted LGBTQ people and populations. Dr. Mitchell Rosen is an associate professor and director of the Center for Public Health Workforce Development at the Rutgers School of Public Health. He has been actively involved in New Jersey's response to the pandemic and led the development of the state's curriculum for the Community Contact Tracing Corps. I'm Michelle Edelstein, and I oversee marketing and communications for the Rutgers School of Public Health. With that being said, I'd like to pass it on to Dr. Branch, who will introduce herself.
Morning, really delighted to be with you all. My name is Anna Branch, and I'm the Senior Vice President for Equity here at Rutgers University. And I'm also a professor of sociology. My work is at the intersection of race, racism, and inequality. And I specialize in the workforce and economic inequality. Happy to be here.
Next, we have Dr. Breedom.
Good morning, and thank you for having me. It's a pleasure. I'm Arturo. I'm the executive director of the Nicholson Foundation. I've been here for 4 years, overseeing a foundation that focuses, our mission is to improve the health and well-being of vulnerable populations throughout New Jersey, with a focus on 2 priority areas, health and early childhood. Prior to joining the foundation 4 years ago, I was the Deputy Commissioner for Public Health Services at the New Jersey Department of Health. Thank you, Michelle.
Next, we have Dr. Castrucci.
Hi, I'm Brian Castrucci. I'm the president and CEO of the De Beaumont Foundation. We pretty much focus on improving the governmental public health workforce, and I'm just super happy to be here today.
Wonderful. Dr. Nwaka. You're muted.
Thank you. Good morning, everybody. My name is Pascal Nwako. I am the Camden County Health Officer and Public Health Coordinator. I want to use this forum to thank and acknowledge all the public health professionals, all the public health workers working in local health departments in the state of New Jersey and around the country, and indeed around the world. They are the reasons why the hospitals are not overflowing with COVID patients and people are not dropping dead on the street. It's because of the extraordinary job performed by public health workers. We are largely invisible and unrecognized. So professionally, I have been focusing on promoting health, preventing COVID-19, and protecting Camden County residents. And that's what I've been sworn in to do. So through health education, contact tracing, COVID testing, and right now, mass vaccination. And what's next for public health is largely capacity building with local health, public health departments. And like you know, we've been cut to the bones. We will be discussing this later during this webinar, but let me stop so far. Thank you.
And Dr. Silvera.
Hi, I'm Dr. Stephanie Silvera. I'm an epidemiologist and professor of public health at Montclair State University and a Rutgers double alum. So I feel very at home here. And like Dr. Branch, the work that I focus on has sort of the through line of structural inequalities and health inequities. And I think that what I've been doing for most of the past year is really following and trying to examine how those structural inequalities are showing up in our COVID outcomes. And unfortunately, we have a lot of work to do. So what's next is, I think, everybody digging down deep and pulling up our sleeves and really looking at policies and trying to get away from blaming people for behaviors that they think bring them to these points.
I also would like to just add to my personal thanks to everyone being here, including to my buddy Brenda Flanagan, who I've spent, I don't know, maybe more time with, like, you know, over the course of the last year chatting than with my husband. I don't know. Maybe that's true. It's possibly true. But I want to just acknowledge everyone here and the work, the reason that this group is gathered. And, you know, it's sort of amazing for someone like me to be able to say, oh, here's the people we should have. And then here they are. And the individuals who are here today are actually individuals who walk the walk. They don't just talk the talk. They like believe it. They live it every single days of their lives. And for those of you who have heard me speak before, you will hear me say too often that academic public health, living behind a computer in an office, is not what public health should be. It has to be advocacy and activism, and it has to be really good scholarship all tied together and giving voice with the people we're working with, to the people we're working with, and empowering communities to really take control of their health and give them the tools to improve their lives. So thank you all for everything you do every single day to improve the lives of people in our state and in our country and in our world. I'm highly, highly appreciative. All right, I think that
brings us to our first question.
First question. Good morning, everybody. I have to say that the news show that I work for over the past year has led almost every broadcast with a COVID story. And Perry's right. I've talked to him perhaps once a week, if not more often. We have, I think, focused on the fact that public health is people. And so the first question is focusing on communication. John Barry, who wrote The Great Influenza about the 1918 flu pandemic, said in an interview, the best strategy, both long and short term, in any crisis situation, and particularly when you're looking for public compliance with your advice, is to tell the truth and then keep telling it. Last night in his speech, President Biden said that he would tell the American public the truth. But the thing is, in politics, truth is relative, and different audiences hear your message differently. So how did we do during this pandemic? What did we learn? What do we need to change? And how do we speak to different audiences? I'm going to ask Dr. Silvera if she can step up and do the first answer here.
Absolutely. So I think the question of how we did is one that we're going to be studying for a very long time. Medical historians are still looking at 1918 to see what went right and what went wrong. And as a matter of fact, my older brother is one of those historians. He works at the Center for History of Medicine in Michigan. So we talk about this quite a bit. I think what we can say definitively is not only was there no real federal leadership up until the last couple of months prior to this administration, but for most of the past year, there was a decidedly anti-science approach that both entertained and created misinformation about the pandemic. And I'm sure most of us would agree that that has cost us lives. 1 year ago, the former president was publicly saying that this was nothing, it would go away like a miracle, it was a flu, or it was just a hoax, while privately acknowledging that the pandemic was real and worthy of significant concern. And unfortunately, because of that, he muzzled the actual scientists and promoted people without credentials or with dubious intentions, which ultimately cost people lives. In terms of what needs to change, I think we're actually starting to see that now. First of all, we need to invest in public health and keep investing in it even when things are going well. And we need to let career scientists lead public health crises without political intervention or interference. We also need to do the very real and important policy work to decrease structural and racial inequalities and to bring those voices to the table, right? Public health should not be about telling people what their problems are and how they should fix them. It should be about listening to all of the members of the community, of our public, and getting their input on what their strengths are, what they need, and what the challenges are, and then address them in ways that are meaningful.
Dr. Castrucci, how would you answer this question?
So that was a great answer, and we definitely need to do the reflection. As a practitioner, I kind of can say we didn't do so good, right? And so a couple things. This starts from our training in public health. We don't have a good enough communications base in our public health training. And so all of a sudden, 3,000 plus health department leaders had to get in front of the media and say, we don't really know what's going on yet. This is a novel virus, and we don't really have the communication skills to do this well. We allowed those who didn't believe that this was important to frame this as you're either going to die from the virus or you're going to die from economic challenges from the virus. For the first time in this country's history, we were debating how Americans would die. Like we didn't ever come together and say, we all have anxiety about this, and this is how we're moving forward. Imagine after Pearl Harbor, if half the country said, well, that's fake news, or Germany's not a threat. So we needed those real communication skills. We needed messaging coming from CDC, and if not CDC, someone else every week. We shouldn't have been doing this as 3,000 separate individual health departments. We should have mobilized our army of health leaders and been consistent with our messaging, right? Because the other challenge of this is the 1918 flu didn't have Twitter. And so in 1918, the person who was running around telling you that flu was a hoax, you just kind of like put them off to the side. Now that same person has 25 million Twitter followers, and they're telling you it's a hoax, and they're fighting against, our messaging. And so we have to reorient and really start training our public health leaders in communication. And if you don't think you need to be as skilled as a politician as a public health leader, you're wrong. Okay, this isn't just the truth and the facts will set us free anymore. We have to communicate and be artful with and aggressive with our communication so that people can make the right decisions with the right information.
Do we have time for a follow? Basically, sometimes the messaging has to shift. The messaging on masks shifted. When will we open? When do we close? The question is, how do you keep people with you when even as you're learning about how this virus is moving?
So I was just going to jump in that I think it's not just about training our public health workforce. I think it's about teaching health literacy and health numeracy to the population so that when a pandemic comes along, we're not trying to explain how the scientific method works to 300 million people who've never heard of it before, who've never seen it. Epidemiology is its own language that most people don't know. And now we're shifting and trying to understand or explain the nuance and the difference between overall mortality rate and COVID-specific mortality and case fatality, which are challenging concepts. And so the fact that we don't have a good, sound foundation of just basic health literacy in this country is a big part of the problem. It allows people to believe the fake news when it's put out there, that scientists are just sort of shooting from the hip and don't know what they're doing.
Brenda, can I jump in here for a second and follow up something that Stephanie said? Because I think this is a really interesting point. My buddy Stephanie here. How do we educate a public? And my people at my school have heard me say this: when we don't teach children science in school, when we don't teach children social studies, so people get elected senators and can't tell you what the three parts of government are. What role does public health have in educating youth so that the future generation? I thought we learned from AIDS. I thought we learned in 1989 what to do, but we clearly didn't. But what do we do to make sure that 12-year-olds, when they're 42-year-olds, in 30 years, have the knowledge base? Anyone can take that. Brian?
But can I just add to that? I think the other issue that we need to really grapple with is that, let's be super clear. Both sides, Republicans and Democrats, I don't think anyone's anti-science. That would be easy. That would be an educational issue. It's that everyone has found the scientist who agrees with them. And so, I remember reading a Scott Atlas Wall Street Journal editorial that said, I want to talk about misinformation in the COVID vaccine, the COVID crisis. And I was like, well, that's fascinating because I think you are the one who spreads the misinformation. But he's a scientist. He wears his white coat. And so I think it's even, it's even more, Perry, because it's discerning. It's not learning just science, but it's discerning what is correct science from incorrect science when everyone says they're giving you facts.
Brenda, can I add to that?
Go for it,
I
Arturo.
think that, yes, we can all agree there's a health illiteracy around the country. The focus today is about what's new for public health. And if there's a health illiteracy, there's even more illiteracy related to public health. And just because you're one type of scientist doesn't mean that you understand public health or population health. As a physician, if I didn't go and get my MPH and work in the Department of Health, I would not understand how to run a disaster plan for a state, for instance, how to react to an infectious disease from a population health perspective. And I think that's the mistake we make. Sometimes we put doctors, I'll say that, in positions that they have no business being in. And we've seen that over the last few years, right? Just because you're not MD, we need more epidemiologists at the table. We need people with PhDs and people that have actually run disaster plans, whether it's infectious disease or otherwise. And I think we have to stop thinking about credentials versus the type of person that understands public health or population health. And I think that there's even more illiteracy in that area. And when it comes to education, I definitely agree that we need to educate our youth early on about science. But right now, I think we need to work with people that are policymakers and do a better job of translating public health to those policymakers. The challenge with that is that funding is needed for that. Having worked in the Department of Health, we spent a lot of energy on that. There wasn't the kind of funding needed for that, translating complicated epidemiology and public health for people that were making the decisions. It's a circle, and you need more funding, and they're the ones deciding about the funding. But we need to come together as a country and really do a better job of providing funding for educating the general public and the policymakers.
Can I jump in here just on one quick moment? Because I think that there's a health equity illiteracy, or just not even a health equity. I want to talk about like health fundamentals in this conversation. And in some ways, the things we needed to do to fight this pandemic, you learned in kindergarten. How to wash your hands. What's the right way to cough right into your sleeve? And there were there were some fundamentals. And so when you think about the kind of higher order management, incredibly key. But actually, I think that's one of the things in this moment that were missed of how much the basics, how much time actually did be spent reinforcing some fundamentals. And so what's the role of public health professionals? What's the integration and education and amplification so that there are some things that we understand as shared? Because we were debating that.
I think a lot of times scientists will also hedge because they don't want to state something as a 100% certainty, and that leaves a question mark in the minds of the public. And there has to be a way to translate that into an effective policy without making people wonder whether it's real.
And when the knowledge changes and we learn new things, how do we make that message that it's not a flip-flop, but we're advancing where we're going? Right. Anybody have thoughts on that?
Sure. So the issue with public health practice is that we go through a period of neglect, crisis, and repeat. All right. So we do that all the time. Like you talk about the HIV/AIDS in the 80s. So, but we have not learned until we learn on how to manage it and keep it consistently. After the pandemic, you see so many health departments will lose staff members that fought the pandemic. Instead of having it consistently and build that capacity, those staff will leave and we will go through another crisis. at the beginning, we wouldn't know what to do because we don't have the manpower, the resources. So until we figure out how to break that cycle of neglect, crisis, and repeat, we will continue going through this.
You're answering question 6.
No, it's great. It's great. I mean, this conversation is exactly where, I think we have to be. And I think, to your point, I think Arturo made this point, which is, when you look at the press and you look who's on the news at night, 80% of the people have MDs. They don't have PhDs. They're not thinking about public health practice. They're thinking about things from a biomedical perspective. And as Brenda's heard me say, I don't know, 80 times this year, human beings are not rational operators. We need a biopsychosocial perspective. And people just don't wake up saying, I want to have COVID, I want to be obese, I want to have a drug addiction. Society and social structures get them to that place. So we've got an education to do. And, I think all of us are committed to that. Shall we move on to question 2? I
just want one comment on that, because Arturo said it earlier, and Perry, you said it. I was very disappointed. I'm not a clinician, but I stood up a whole cardiology clinic last weekend, and I was going to do heart surgery, but guess, the police came and said I couldn't do it because I'm not a cardiologist. But there are a lot of folks on TV news that are claiming to be epidemiologists. I mean, my 9-year-old daughter said to me, I'm an epidemiologist. So like, really? You can go on CNN now, right? So there's no credentialing for public health, which is challenging. And folks, and I appreciate the MD, MPH, but if you had, if you've been an ER doc for 30 years and you took 30 credits, 15 years ago and got your MPH, I don't know that qualifies you as a public health expert. Public health expertise is not degrees. And this is a different conversation, because I saw a lot of folks on TV claiming epidemiologist and public health expert. And I would have loved to ask, like, how does one come to that? So I'm going to try again with the cardiology clinic this weekend. We'll see how it goes.
Yeah.
Yes, thank you for that, Brian. I'm a TV spokesmodel, right? Because I got that credential along the way too. Right, exactly. So let's go to question 2. Question 2 is the following question. I'm going to ask this question to Pascal and Arturo, and then we can break it up, and I've got follow-ups to that. But health officials and government leaders still get pushback when they ask the public to comply with mandates, like wearing a mask or closing businesses. And in fact, we saw President Biden last night begging us to continue to do those behaviors, while at the same time we have states like Florida, Mississippi, and Texas, which are just eliminating all restrictions. Remember Governor Murphy famously saying, data determines dates. Why do you think and we may have touched upon some of this already, but why do you think there is so much division over issues like these? And how do we do better? Pascal, you want to start us off?
Yes, also the governor said public health determines economic health. So, so that's also a good thing to start with. Yes, it's been difficult for the public to really know what to do, because at the beginning, people were in denial on what's going on. And also, I will give it to the public, because public health was in denial also. We didn't know how to really grapple with the influx of the coronavirus. We didn't start early to plan, even though we go through all our resources that we've been using over the years. We've gone through going through pandemic preparedness and things like that, but nothing prepared us for the influx, for the level of coronavirus. So the health department and the local health department, we are the boots on the ground. We've been teaching to the public on hand washing. It's not new, like Anna said, it's nothing new. We started that from pre-K, knowing how to wash our hands. It's been going on through the flu seasons. We've been teaching every time during the flu seasons that you should wash your hands. When you sneeze, you cover your sneeze. So, but when the pandemic hit us, it was more than that. We have to make the public understand who we are. Neighbors ask me, what do I do? When I explain, they shake their heads and they still don't understand it. Okay, so we have to sell ourselves. Yes, some people did not believe at the beginning that the pandemic was real. People were still in denial, and the government didn't help us out too, because when there's a problem at the head, then the tail becomes, it goes down the tail also. So the public was confused. Do we wear masks? Do we not, don't wear masks? In Texas, it's open. In New Jersey, it's enforced. What do we do? So there has to be a general consensus that public health speaks first and every other person's follow. So it's not politics. It shouldn't be politics, all right? Just like the governor says that public health determines economic health. You have to be alive, you have to be well for you to talk about the economy and for you to progress. So let me stop so far.
Agree with everything that Pascal just said. What I'm going to add, we already talked about science literacy. That's part of the problem. You know, basic science facts like washing your hands, et cetera, and germ theory and all that. That's part of the problem. The other big problem, Perry, is that there is lack of coordination on messaging, and more than that, but specifically about messaging to the public. Lack of coordination from the federal level to states, and then from states to local departments. As Pascal knows, you know, we worked together as best as we could when I was Department of Health, but it was a challenge because of time constraints, et cetera. We had other crises back then, but what we need to do is have a national coordinated plan on what to do with these disasters, which includes improved messaging. And then I think it was Brian that brought up earlier, the other problem is social media, how people are using social media more and more to get their information. And I think the public health world needs to get more involved in social media, have a real plan for spreading information. Again, a coordinated plan for educating the public about public health through social media. Again, you're up against a world where there's so much misinformation on social media, and there are people interested in spreading that misinformation. And all that takes, though, is a lot of funding for those in public health, like Pascal, people at the state level and the federal level, to be able to do that, but doing it together.
Can I jump in here? Because I think one of my roles on this panel is going to be keep on coming us back. Because I think one of the underlying issues, the differences between what you're seeing in Texas and Mississippi and New Jersey, is a fundamental care structurally in terms of policy for the public. What is the floor, right? And so we're talking about, like, you know, public health is fundamental to economic health. There are a lot of people in good public health times who were economically impoverished, and the circumstances of their economic impoverishment meant they were not healthy, but we weren't talking about that. So now we have a context where you've got a global pandemic that's creating conditions of kind of mass uncertainty, and we're asking people who were already at the brink to not do something, right? So the pressures, the very real pressures are, how do we manage a kind of public health crisis when we don't have a floor, when we don't have a social floor that ensures well-being, where people can feel confident, if I go home and stay home, I won't die of hunger, right? Because that's where we were. That's the difference between the American public health response and what happened in Europe, where they said, no, we'll pay your rent. We'll make sure you can eat. So we can't separate kind of the mask and the public health guidance from the economic circumstances.
Okay.
You're muted, Perry.
Something else I want to add to this is we need the populace, the population and policymakers and partners to understand the breadth of public health and its role in non-traditional public health activities, such as equity, justice, social determinants, education, income, housing, etc. We are not just environmental health, because public health, people always think that public health is just environmental health, but it encompasses all these things that we need to also think about them.
I love both these comments so much, because it speaks to something that I have been really pushing on the last year or forever, which is the biomedicalization of public health. And if we believe that, and if we believe that every health condition is driven solely by bacteria and viruses, without an attention to the structural inequities that drive these issues right out of our minds. I cannot tell you, my friends, how many times I've been in my work in HIV at meetings where I've heard my fellow colleagues who are MDs, good people, but MDs, no, sorry, Arturo, say things like, well, why don't people take their meds? Why don't they just take their medications every day? What's wrong with that? And I'm like, well, because she has 4 kids and 3 jobs and is barely able to get by. Her meds are not her number 1 priority. Keeping her family together and keeping a roof over their head is the priority. And it speaks exactly to the economic disparities that continue to fuel the health disparities in our country. And can we all agree that we're tired of like documenting health disparities and we just need to move to enacting health equity? Like, we know, like, let's just change it.
Agreed. And the piece I'll just add here, and then I'll be quiet, is we're not actually willing to hold that intellectual complexity. No one is, right? So we actually want to have a simple conversation that's about the economy's doing better or the disease is going down, that we're not actually willing to have and hold the disease is going down, fatalities are going up in this population for these reasons, right? So the willingness to say these things are connected, and I loved your point, Pascal, which is public health by definition should be, for those who are doing it well, looking at all of these things, right? And that's what we miss when we shift to a population health frame.
Well, and I would add, Dr. Branch, I mean, you know, we have to look at the inequities baked into our society as what made us vulnerable for the devastation of the virus. And so if you're talking about getting back to normal, normal was a society baked on racism. It was a place of police brutality. We need a new normal. I mean, we had 121 consecutive months of economic growth through the end of 2019, but the federal minimum wage didn't change. And so when listen, let me be super clear. I'm an epidemiologist. I have a DRPH in public health leadership. But if you ask me to quarantine, and that quarantine, even if I'm asymptomatic, and that quarantine means my daughter's not going to eat, I'm going to listen, man, I'm going to work. And so everything, not having paid sick leave, income disparities, housing, folks who are rent burdened, this was the soup. Right? This is what made this devastating. And if we don't fix that, the next time this happens, we might not, I mean, this was the mortality rate was not inconsequential, but it was low. Next time, and we all know there's going to be a next time, we might not get so lucky.
It's watching the response to the lack of more vaccination in communities of color will bring some J&J vaccines into this neighborhood. Now everything is fixed. No, there is still the underlying systemic inequity in the health system and in a lot of other areas. But just bringing the vaccines there does not fix the problem, the public health problem.
And one thing, can I just jump in and say that, we saw communities of color dying at higher rates, not because some biomedical reason. It's because they're more likely to be concentrated in areas of poverty and in these jobs where they did not have a choice to stay home and work comfortably because we wanted to be comfortable, right? We still wanted our Amazon package the next day. We wanted our groceries delivered to us. And now here we are, we're a year later after saying everyone's a hero and clapping and debating whether or not they should have a living wage, whether or not they actually, we're trading our comfort for their humanity. And that conversation isn't happening enough. And, when people have said, well, public health should be about environment, right? The environment. Yeah, the social, cultural, and political environment, right? And the reason when people say, oh, well, work harder, do better, get an education, we have to go back and look at structural inequalities that go back to housing segregation, right? I just read Ijeoma Oluo's most recent book, and she has this chapter, Works by Design. Right? We're acting like this is a surprise. This is how the system was set to work. And much like our reflections about the early 1980s and HIV/AIDS, I question if we're going to turn around and do better because works by design. Who was most hurt by this? Right? It's the people who have been hurt for the history of the United States. So are we going to suddenly start caring? Right? We need enough people to speak up so that we don't just go back to our status quo.
And to Stephanie's point, I just want to add one thing here because I think the HIV thing is a big one, and it's it's still around. We still have 40,000 new infections each year. Like HIV, I don't know how many times I go to meetings and people are like, there's like a pill now, right? It's fine, right? I'm like, no, okay. But we look at HIV in our country or not. What do we see? We see primarily young, gay, and young gay men and women who are Black becoming infected. If this is not, again, the illumination of what we have seen with COVID-19, then I don't know what is, right? It's like substitute COVID-19 with any health disparity, and you're going to see Black and brown populations most at risk, which gets to the beautiful point that Stephanie made about, these environments, right? The family, the political environment, the state, the country. Thank you.
I just love it, but can I say one thing?
Yeah.
Part of also building on what Stephanie was saying is, if you remember a year ago, the way the conversation shifted when we realized which communities were being impacted. And what I mean to the humanity point specifically, we started having a conversation that was about comorbidities and not one that was about exposure. We really quickly said, if you weren't obese, if you didn't have diabetes, then you wouldn't, so we don't really have to worry about it, right? And so that inherently is about how we're willing to hold humanity and the way in which science can be used against communities, right? As opposed to in supporting and raising the kind of larger issues.
Dr. Rosen, you want to go to the next question? I think we're going to go to the question. We're going to switch things around, but we're nimble here, right? We want to keep, this is an amazing, amazing conversation. And I'm going to turn it over to Mitch, who's going to pose the next question for us.
Thanks, Perry. During the last year, we were just talking about heroes. So, Stephanie, I think you brought it up and others have brought it up. Our governor signed a resolution on making March 9th COVID Heroes Day. But public health workers weren't specifically included in there. It said healthcare workers, supermarket workers, transit workers, but healthcare workers, not public health. And we've seen so much of this over the last year, the workers, the essential workers ensuring that food is on our table, supermarkets are stocked, and these workers include immigrants working in the fields and in meat and poultry processing, supermarket workers, transit workers, and so many others. And we see nurses and physicians on the front lines of healthcare providing essential care and treatment for those who are critically ill. All of those workers deserve our highest respect for the work they do. We couldn't be where we are without them. But the term public health is now in the forefront of everybody's mind. And we've heard this before. This is the opportunity for public health. We heard that after 9/11. We heard it after anthrax. We heard it after the hurricanes and other natural disasters. But again, there's a lack of understanding what public health is. And public health workers are relatively unseen in the eyes of the public and not represented at Heroes. So what can we do about this? How can public health and the work of local health departments be magnified to show their critical work that protects the public and prevents disease? I'll ask this to Brian, Pascal, and Stephanie, and then others will jump in. So Brian, you want to kick it off?
Well, I think, Bonnie Raitt told us, let's give them something to talk about. And so we have to get out there and give them something to talk about public health. There were far too many, and I, I'm as equally critical of the media as I am of my own profession. But we all know that throughout the country, there were a whole bunch of public health officials meeting with school superintendents and business folk for the very first time saying, hey, I'm closing your school and I'm closing your businesses. Good to meet you. I'm the local health department. That's not a good first date, right? And so we needed to be out there. This is the time not to think about response, but about resilience. And resilience means everyone, Pascal, I'm sorry. I live in my in-laws and I used to live in Camden County. And this is the first time I've met you. And I'm like, this is awesome. Now I know who the Camden County health commissioner is. And I'll be there in a couple weeks seeing my in-laws since everyone's been vaccinated. You need to be so front and center. Every one of our health commissioners need to be so front and center, and we got to stop being afraid because the governor is going to take us out or the mayor is going to take us out, and we have to be allowed to speak science. But on the other side of that, we've lost 200 health commissioners to resignations, terminations, et cetera, because at the end of the day, all of us working in governmental public health are employees, and we all, that famous phrase, serve at the will of. And so this is part of the challenge where we're limited in what we can say. But if public health if everybody doesn't know Perry, if everybody doesn't know, all of us here, plus everyone else who's doing the work, because those doctors that we talked about, they're all over Twitter. Med Twitter's a thing, and that's where producers find them. So we have to, again, let's take the Bonnie Raitt anthem and make it all about public health.
Thanks, Brian. Pascal, go ahead.
Yes, public health is invisible, and the work we do is largely invisible and unrecognized. Example, if it weren't for the efforts of public health, our health system would have been overrun with COVID cases and likely collapsed. Public health efforts to reduce the spread of disease have been vilified. We are key to surviving public health, key to surviving the pandemic have been reduced because of people don't know what we do. Let me tell you, the fire department, the police department, they don't start hiring when there's an influx of burglary or fires in the cities, but they build capacity over time. So why not public health build capacity over time? Because we have been cut to the bones. We have been cut every month, every year by year, we lose staff members. When staff members retire, they're not replaced. And you wonder why the pandemic hit us so hard. It's just because we did not build that capacity over time. Yes, we need to be out there. And that's what we've been doing within the past 3, 4, 5 years. New Jersey got together and we came, all the public health organizations in New Jersey came together under one umbrella called PHASE, Public Health Association Collaborative Efforts. So we are speaking with one voice, everybody, because we have health educators here, nurses here, we have health officers here, we have local board of health associations here, and we have other organizations that everybody, we are coming together now to speak with one voice, and it's advocacy. Why am I saying this? Because the police department have a strong police union. The fire department, they have a strong fire union. So you don't take away their budget. You don't slash their budget that way because they will go public. We need advocacy in public health. We need people to go to the state house. By the way, vaccination. Because of the pandemic, we forgot that we were close to passing over the state house, passing a vaccination vaccination in New Jersey that all the students should be vaccinated. So, but we have people in the state house camping there for weeks. When the public health professionals go in there, they will be shouting at them, murderers, killers, because they don't want that bill to pass. That's the word I was looking for. They don't want the bill to pass. But we didn't go out there to say, by the way, this is our job. If you vaccinate my child, it will prevent your child. If you vaccinate your child, you prevent my child from getting the disease. Vaccines are there for preventable diseases. So what's the problem here? We are not at the forefront. We are not fighting. We just go into our offices. We just do our job and shut up. This is not the time. We should be upfront, out there, speaking public health, making people believe and see what we do every day. Because we are the boots on the ground. People from public health departments every day put their life in danger. When at the beginning of the pandemic, when people weren't going to nursing homes, long-term care facilities, we all suit up and started going there because the state did not have the facility. They did not have the manpower to visit each and every one of them. But we never went there before. But we had to invent a way to get to them. And what did we find? Bodies of people that have died and packed in one of those facilities. If not for public health, this wouldn't have happened. So let me start forth. I'm emotional about this, though.
Yeah, no, that's great, because we need to make public health at the forefront and do the advocacy. You ask people about clean air, clean water, people want that, right? And that's public health that's doing that. So, public health issues poll very high, but we seem to miss the connection between, what we do as public health and how the public sees these issues. And How can we do better at that? Stephanie, any thoughts on that?
I was just thinking as you were saying that, I think, these issues pull high when it impacts us. I think where it starts to fall apart is where it impacts people that are populations that we're not part of, right? There in Mississippi, I think there's still large populations of people who have no water, right? We stopped talking about that. And again, it's a matter of recognizing other people's humanity, as well as, even if that doesn't work, a better, healthier society. If everybody's healthier, we do better too, right? So if you want to look at it from a selfish perspective, we can look at it that way. We can look at it from an economic perspective. Having people work is better. And if they're sick, they can't work. If we pay them a living wage, they're healthier. So I think part of what getting people to care is, one, recognizing that this, it helps everybody if everybody is healthy, but also, this connection with politics and policies. And I think somebody had put in like, okay, so but what now? What do we do? How do we get there? I think we need to you need to know who your representatives are at the state level, at the federal level. You need to know that you can call them and harass them. Call them every day. Tell them what your complaint is. That's their job. It's their job to listen, right? They are there representing you. We need to look at the voter suppression laws that are trying to be enacted across the country right now. It's going to disadvantage some people and take voices out of the conversation. We cannot allow that to happen. And so, the public health is inherently political in that our funding comes from the government, right? And so we need to be engaged. We need to make because the 50 wealthiest people in the country had their wealth go up by 40% last year, while other people are struggling and begging for an extra $1,400, right? There's a reason why that's happening. And so we have to use our collective voices to advocate for everyone and advocate for the people who don't have the power right now.
I'm going to add something to what Stephanie said really quickly, and I want to implore me and Anna and Brian and Stephanie who are working in schools for the following. Graduation, the last time I had an in-person graduation, which was when? In 1923, I don't know, 2 years ago. My speech was about how politics and public health cannot be separated, right? And it was just like, it's very clear to me, right? Yet there's a group of people out there who think that good science and politics can't go hand in hand. And that's just garbage. What is our responsibility? We are in schools of public health. We run foundations that work with schools of public health. What can we be doing better in our schools other than to ensure that, yes, our students know odds ratios, congratulations, right? But that's fantastic, good for you. But what can we do more effectively in our curricula, in our experiential learning for our students to make sure they have the voice, right? And the communication skills and the activism and the advocacy to be able to do these very things. Any thoughts on that?
I want to speak to it, but I want to take a step back because there's a point that Mitch made in his last question that I don't want to miss. And it's what you said, Pascal, about what's different between what's happening with the police, what's happening with the fire department, and what's happening with public health. And we don't debate, again, you loved your point, right? That we don't go look to hire firefighters when the fire happens, right? We sustain them. But on the other side, there are lots of towns that only have volunteer fire departments. So in what ways do we enable a kind of structural gap, right? In who's supported and who's not? I want to point to the role of television, right? We've got television shows that celebrate the role of firefighters, that celebrate the role of police officers. We don't actually even see the stories told. So when we go back to the beginning of our conversation of what's the role of science, what did we learn from the 1918 pandemic? What does illiteracy mean? How do people understand the role of public health workers as different from healthcare workers, right? And so there's not just the kind of educational literacy of how do you take care of yourself, but an education of the public of we are the people keeping you safe, right? In these broader, much more complex ways. And in some ways, to get to the question you were asking, Perry, around what does that mean for the curriculum? Getting public health workers to understand that and to articulate it, right? That it's not just the odds ratios, right? That it's not just the kind of mapping. It's saying my role is to talk, as Brian was saying, to the school commissioners before I close them, right? Thinking about what's the relationship, right? That you actually have an embedded community role to play. And that embedded committee role is not political because it's embedded, but it's the actual work of the job, right? And that is something I don't think we've done as much, but it's moments like this when we're missing in the conversation, or public health is missing in the conversation, that we ask, well, why are we missing? Well, if you didn't frame it in that way, then you're going to be missed.
And the voice has to come from outside of public health also. It can't just be us talking to each other, and it's got to be, after 9/11, we needed the expertise of the Office of Emergency Management to realize that public health had a role at the table and was very important. And so how do we do that? How do we get the outside of public health to see the importance of public health and be part of the table? And also, how do we get the public to see the value of public health? And then they'll be our advocates for us for funding, like the police department and the fire departments. Without that kind of external groundswell of support, we're talking to ourselves. How do we do different?
Can I just, something that Dr. Branch said, I want to just pull out a little more, and then I'm going to answer your question.
Yeah, great.
All of us played teacher when we were a kid. We played doctor, we played, firefighter. We didn't play epidemiologist, right? So my father-in-law, who is a physician, gave my kids the little dress up doctor, outfits from Melissa and Doug. I took some of the stuff out, I put a notepad in, and we did a little disease investigation amongst my child's dolls. But it has to start there, because even our health classes are mostly about washing our private bits. It's not about community health, right? Especially, and let's just be super clear about this, especially for rich white kids growing up, right? Because the community doesn't impact our health. Like, I was certainly not a rich kid growing up, but I was a white kid. And in my community, I didn't have to worry about housing or environmental racism. And so it wasn't until I became it wasn't until I became a public health professional, I was like, look at all these things that I had this advantage. So I always tell the story. A couple of years ago, I was diagnosed as a type 2 diabetic. My A1C was 10.4, which is impressive. It took me like 3 months, and I was back to 6. But of course, and people will be like, yay. I'm like, no, don't applaud a rich white guy who let his health go to shit. Like, let's be really clear. I had to work really hard to overcome my privilege to have a high enough A1C at 10. And it was able to go right back because I just leaned into the privilege that's in my community. And this is the stuff we have to start baking this in at the start. And to answer your question, Mitch, we need to get businesses involved. There's now the Health Action Alliance has been launched. We just did a report last week on 7 ways that business can work with public health, because here's the thing. What COVID has taught us is that our economic prosperity, our safety and security is all dependent going forward on a robust public health system. And if we choose to ignore that, then yet again, our economy could come to a screeching halt, because we spend $750 million on defense, but show me a foreign nation that's ever taken 500,000 American lives on American soil.
I think it's important to note that there is a window of opportunity that this pandemic is presenting. It's an economic windfall here in terms of the American Rescue Plan. There's going to be billions of dollars that are coming in. When you look at how this money is going to be spent, is it going to be spent on ongoing training for staff, better computer systems that link a statewide and a national network? At this point, our computer systems are all over the place. Are we going to see consistent funding and maintenance? Because Dr. Nwako was right. When you have a crisis and then it moves on, people and health departments get shrunk, they shrink. And then suddenly you find that the playbook is put up to the side about how to handle a pandemic. The stockpiles are not thought of anymore. And we begin to get back down to an unprepared state. The question is, how do you maintain trained staff when, for example, you've got 50 people in your police department? How do you keep a high level of people in your public health department and justify it after the pandemic goes?
Yeah, can I say sorry, Dr. Breedom. Let me go back to what Perry asked regarding how to engage students in more of advocacy. I'm happy you asked that, Dean Perry. it's very important that students, especially those in masters in public health, visit the state house, know how bills go from step 1, step 2, step 3. It's very important because at the end of the day, if we do not do that, public health might be extinct. We need to, local public health, we need to let students know how does a bill progress from first step, second step before it passes. That's advocacy. I know we study everything in the classroom, but when you go to the local health departments or you go into a public health arena, it's a different ball game. And students might have to spend more time going through internship in local public health departments or in public health agency. That 200 hours doesn't cut it. All right. So it might be a whole semester if they choose to do that. And it will make them more effective when they're out there in the field. And let me stop so far. Sorry.
Pascal, I'm going to jump in and then go ahead, Arturo.
Yeah, I want to add to what Pascal just said, but in a minute, I want to, in a way, to answer Perry's earlier question about public health students. But before I do that, Brenda, you raised a really important issue. One of my concerns is, we're very reactive as a society. We're not proactive, right? And I worry that the money this windfall of money that's going to come to states will be either A, squandered in a way that isn't as effective as it should be for the long term, or B, it'll be a total infectious disease focus, as opposed to what's been discussed before, looking at the infrastructure issues that we have, the lack of equity, the non-infectious, our foundation and others around the state and working with state government right now, we're focused on improving the health of mothers and infants in the state. It's the statistics around the country are appalling where we rank. That's not necessarily connected to infectious disease. That's more of an infrastructure issue. So we need to be focused on thinking long-term, be more proactive. And as public health experts, we need to be influencing that. And related to that, Perry, I think one of the challenges, and I teach a course at another university with public health students. And the focus there is because of what I learned at the New Jersey Department of Health, is that a lot of people come into work into government, into state government. And that's where the money is right now for public health, right? Some foundations support it to some degree, but it's really with government. Not understanding the infrastructure, how decisions get made, how people are put into positions without necessarily having, because the way legislation is written across the country, the majority of health commissioners, as an example, don't necessarily need to have any public health background. Think about that for a second, right? Departments of health. And that's a challenge. It's usually somebody that's well connected and known and trusted by the governor of that state, but they don't necessarily have that background. They're just and there's a lot of legal focus around state governments and certainly the federal government, but not enough epidemiological focus, public health focus, population health. And I think when students graduate, they should understand the infrastructure, how that infrastructure is set up, what laws exist in which states, and how they might be able to influence that before you walk into a state or local department. Pascal knows exactly what I'm talking about. I know that. And because it is stunning how, and that's the other challenge too, the turnover rate at the federal, state, and local levels, more in recent years than ever before, is just part of the problem. You have people that are learning on the fly during this pandemic. That's not the time to learn, what to do during a crisis. So I'll stop there.
These are lessons learned that we've said this after HIV, we said this after 9/11, we've said this after Sandy, we've said it after, we keep on saying this is what we have to do. How do we do it? After 9/11, lots of money came into the state for public health preparedness. We bought a lot of things, we bought trucks and we bought other things like that. And money was transferred from core public health issues in local health departments to preparedness, which then bled the workforce from working on core issues to preparedness issues. And once that preparedness money went down, so did the population of the workers. What do we do? How can we change that? Arturo, Pascal.
Well, I'm going to say one more thing, Dr. Branch. Go ahead, Dr. Branch. Go ahead.
There's a broader point that the lessons learned from 9/11 and what happened to public fire, it wasn't because the broad American public decided Homeland Security was important, right? That wasn't what happened, right? And so when we talk about 500,000 lives lost and being clear, we can't point to a single attack or external threat at that level, right? So what is the kind of global response, right? And what happened when you look at the kind of growth in police, fire department budgets and the kind of exchanges that have happened as a result of the kind of 9/11 attacks and what happened thereafter, what does that mean as a public health model, recognizing that our public well-being poses the same risk? Because the mistake for public health would be to think that it's a conversation that you can have with yourselves. It wasn't the police and the fire departments who sat down and said, let's talk to each other, because the reality, just like public health, is within the FBI, within other aspects of the policing and law enforcement community, there was a recognition that there were risks. It just didn't actually result in kind of the national reaction until 9/11. So as Brenda was saying, this is a unique moment. And so where is public health on the conversation for a national response that doesn't just say our curriculum needs to shift, but what is the kind of core organization that doesn't allow small threats to be missed? How do we understand that health is not just local or national, it's global because of our accesses? And we will miss that if we keep having a local conversation about our curriculum.
Yeah. So those are really good points. And Mitch, to answer your question, there has to be a coordinated effort across the country to do something about this. And I think the School of Public Health can be part of that effort. I know that the Association for State and Territorial Health Officers would welcome any ASTHO, if you're familiar with them. They're based in DC, and they are a not-for-profit that really tries to push this forward. I'm sure they would welcome, and they're going to try to take this, Brenda, as you said, as the opportunity to finally get something done, because if we don't do it now, it's never going to happen. But also working not just directly with state government, but as a strategy that we use at the foundation is having that public-private partnership come together, finding that foundation that can help really partner with state government and national or federal government to really start to make that change.
Yeah, and if I could just offer, so we can like tie this one up and go to the next question. And this is a shout out to my friend Rita Kelleher from ASPPH, who's on here somewhere in the Ethernet, that a meeting of sorts at our annual meeting of ASTHO and ASPPH seemed like a really, really, really good idea. Because here's an opportunity for the schools and programs to meet with the people who are working actually in the community doing the work. Number two, I implore all of us who are running schools and programs in public health to have people like Pascal and Brian and Arturo in our classrooms teaching, right? Instead of the people who are just in the academy doing research. And I'll leave you with this one final thought about schools and programs in public health. A person said to me not so long ago that amazing schools and programs in public health were built around strong EPI programs. And I said, hello, 1972. I said, good, strong, amazing schools and programs in public health are built around social justice and health equity. And if we can hold on to that idea right now and alter the way we think about public health and public health education, we're going to be able to accomplish these things. And by the way, my one television program that actually does public health stuff is New Amsterdam, if you haven't watched it.
Yeah.
It actually touches it in a really effective way.
So, Barry, I cannot agree better. The problem, we see this all the time, so that's why it's so. I wish I'm not part of the panel. I'll be asking you all a lot of questions. So we see this all the time because we have gone, like I said before, we have gone through neglect, crisis, repeat. And in 10 years, something else, God forbid, will happen and we will find ourselves not being prepared. So what's the solution? Capacity, building capacity, building capacity. You cannot stop building capacity because you don't know when the next, let's put the health department, public health, like a fire company, all right? They don't stop, just leave one person because they haven't had fire in 3 months, because the next fire might come the next hour. What do? We have figured out what to do. if you all remember the BT grant, 10 years ago, we had, or 12 years ago, we had close to 600,000. Today is half of it. Actually came up a little bit because of the pandemic. So we were cutting staff members all through. So how do we keep these staff members that we all hired now engaged so that we keep them through the next pandemic or the next thing that's coming into public health? Is through cross-training. Somebody that, if those staff members can do other things at the health department, then we have them ready, prepared for the next pandemic. You don't lay them off. You don't just let them go because that's the end of the pandemic. But this is what we're facing. We need people to go out there and advocate for public health, the state house. Everybody, when the people go out there to go out there and say that vaccination is not the thing, that's a good thing. They call them the people that are not for vaccination. Okay, when they're out there saying vaccination is not a good thing, we should be out there saying vaccination is a good thing. We should all prepare, put ourselves together. Everybody agree that we have to sell ourselves. Public health don't know how to sell themselves. We do not know how to sell ourselves. And when we realize how to do that, people will know what we do. People will say, oh, public health is a problem. We are not a problem now because we all go do our job and go back to our houses. We do not go more than that. We have to be out there. We have to let the public know what we're doing. But if we don't do that, we'll continue getting our budgets cut, and the police department and fire department, nothing wrong with that. They will be getting all the increases while we get all the decreases.
Right, we've got to be out and loud. And as a good friend once told me on the phone a week ago, if you're going to be out there pushing, you got to be willing to take the punches that go with it. So I'm willing.
Can I add one
Stephanie, go. Yeah, I was going to point to you, Stephanie. Go ahead.
Because you talked about what we can do in the academy, and I think so one of the classes we have in my program is community organizing and advocacy. So teaching our students how to actually be out and loud and get your hands dirty. I think the other thing that is maybe more of a inside the family conversation is, who do we hire to teach our courses, and what is the tenure process like, right? If we want to engage the community, we have to be doing community engaged work. And that takes a lot of time to develop those relationships. And if you're on a 5 or 6 year tenure clock, it's not happening. So it means that you don't start doing that work until after you have tenure, if you get tenure, and who's doing the work and who wants to do the work and who brings into the academy anyway. Right. So the type of work that centers, actually changing structures and doing social justice and social determinants work is not the go out and do a quick cross-sectional study or a case control study, which, you can bang out in 6 months. Right. That'll get me a publication, but it won't actually change the world. And so we need to think internally as well as the connections we're making with community and how we're acting with politics. This is a complex and nuanced issue we need to address, because otherwise we're going to end up back here again for the next big problem, whether it's a pandemic, whether it's a 9/11, whether or not it's a hurricane. We're going to keep spinning in circles.
So I'm rocking in my seat. Me and Perry are just like,
yeah.
Well, because the piece of this too, and so since we're talking about the institution academy, we can't let NIH off the hook either, right? Because we're talking about the federal government, the role of kind of state level organization and federal level organizing and funding. But the other major source of funding is the National Institutes of Health. And how has it centered and grounded community health approaches, right? How has it valued and created space? And so if the bodies that are responsible for doing that don't see this, the emphasis on the kind of biomedical approach is grounded in where the funding is, right? And so if we're going to take a systems approach, let's take a systems approach and understand that's influencing who gets tenured, that's influencing who's at the table, that's influencing whose voice is at the table. So yes, just yes to all of it.
And if we don't, I feel like I have to say this because we have to say this. We've spent a lot of time this morning talking about the structural inequalities in our society and the isms that exist out there. that perpetuate the disparities that continue to exist. Those isms exist in academia: racism, misogyny, homophobia. And if anybody thinks they don't, they're out of their minds. They're actually, they're just micro and hidden behind fancy words. And
they're not micro, they're not hidden.
They're macro.
And I would add that it's not just in the academy, but they are our society. We can't we can't have this conversation as if the academy and the state aren't in this, aren't implicated. Yes. Right, the visibility. And so our willingness to wrestle, our willingness to grapple, our willingness to name is grounded in where we know the resistance will be. Which publics we cared about, right? Who we were willing to focus on. That's what all this is really grounded in.
Right.
So okay. Soapbox.
Is there a class on politics in public health?
Well,
okay, because just like Arturo said, when you come into public health, you don't know how the hiring goes. You don't know how budgeting is. So sometimes you have the best candidate in front of you, but the higher ups will tell you, do not hire that person. This is the person you need to hire because of X, Y, Z. So, and that now, with every experience that person has, will not go down to the drains. And then you deal with somebody that might not give you the best output, but you are bound to hire that person. So before I did not actually, I say I'm not a politician and I say I don't like politics, but we are all embedded in politics. You can't separate public health from politics because that's who pays you. That's where your grant comes from. That's where your budget comes from. So if you're not ready to be with the politicians and become a politician, then public health might not be for you. I think that's the first thing that we have to let the students know going into public health departments and going into public health schools, because days are gone when you just come in, do your work and go home. If we continue doing that, we'll be extinct. We need to be out there again, advocating for public health through any way, shape, or form that we can. That's the way we have to survive and prepare for the next pandemic.
So I'm sorry, Arturo. Let me just say that really quickly, and then I'll send it over to you. And hold our public health leaders accountable, right? So which means agree with them and support them when we think they're doing what would work, but also question them when they're like my friend Dr. Silvera does, when they're potentially not doing such good work, and hold them accountable. We need checks and balances. Arturo.
Yeah, I was just going to add to what Pascal said, is that the other piece of that is we all need to learn and teach our public health students how to communicate. We started a conversation about communication. It comes back to that, because when you're talking to a politician, you have to use a different language. Remember, the majority of people that are policymakers in politics do not have a science background and much less understand public health. And we have to use language, even instead of using the word public, use population health, because public is a trigger word for many people that is negative. Making it very straightforward for people to understand. And that's a tough thing to do. But I think most of us graduate from schools of public health and whatever we do without that communication piece. And I think that's hugely important.
So I want to pump in here with a caution. Okay. And so, I understand where a lot of students come into public health on the political spectrum. We have to remember, public health is not a side of the aisle. Public health is the foundation on which the house is built. Right. And so if we are only public health on the coasts, if we're only public health in blue cities, and so our activism and our idealism has to be tempered, is probably the wrong word, but it has to be packaged with impact and bridge building, right? Because right now we know that there was high rates of vaccine concern among Black America. And I think there was a very thoughtful effort to help to address that. And now we need to pivot over to Republican America, because we are only going to be as safe as the group that is vaccinated the least. And so, when I do teach, when I interact with students, I just want to remember, hey, there are 27 states that are Republican governors who have appointed health commissioners, and we have to help them help us, and so I just wanted to put out that caution.
I'm with you. I'm absolutely with you. And the notion, that's a good tweetable, that, you know, that the public health is the foundation on which the house is built. Because the piece of it that Pascal was saying, that I completely agree with, is it's being politically savvy. It's not changing your science in response to the politics. That's not at all what he was saying, right? But it's understanding. And to the point you were making, Arturo, a moment ago, it's actually resisting the push against public and toward population health, because that actually means something different, right? When you say, well, we're going to have a kind of population conversation, and it's attending to the tension among publics, but it's being sensitive to the political concern, right? The reality that we haven't been willing to kind of name and support all of the publics. And sometimes our attentions, because politics is politics, is grounded in awareness of some communities over others. The role of the science, the role of the public health professional that is savvy, that is grounded in civics in some way, is to be able to say, what you want is a well population. What you don't want is a kind of explosion over here because you didn't attend to this. So to help them to see why investing in the public health broadly is in their best interest. Because here's the thing, Democratic or Republican, the conversation that they will all say they believe in is that they want some level of good. They will still, like the way, so the role of public health, if we think about it foundationally, is to not allow yourself to be dismissed and minimized because you want to attend to the care for all, right? But to show how the care for all is actually grounded in that foundational understanding of where public health sits.
Right, and it is about the science. And by the way, the science shows if you focus on equity, everybody wins. It actually improve population health, reduce healthcare costs, and elimination of disparities, hopefully one day, right? But the point is that if you focus on the science, Brian, you couldn't have said it better. You know, focus on the science. It's not about the politics, it's about the science. Everybody wins.
And the structures, you know, the structures that undermine the health of, you know, people in the cities on the coast, undermine, there are structures that undermine the health of people in Appalachia, right? And so it's like those are the you know, those foundational issues, while they might manifest differently in different populations, are what we need to empower our students to try to understand, right? And that's, I think, what we're saying here. I'm going to turn it to Mitch, who's going to do one more question, and then we're going to turn it over to people who are on our meeting today questions. And we have like over 250 people on this webinar today. So thank you all for being here. Go ahead, Mitch.
Great. So if you have questions, put them in the Q&A box and we'll get to as many as we can. But I want to ask a question about purchasing power of the federal government and how that was impacted. And we saw the impacts that COVID had on workers. We saw nurses wearing garbage bags. We saw N95s being reused. States outbid each other for PPE, and then watch the federal government swoop in and commandeer those shipments. The federal stockpile was bare, supply chains for critical materials broke. How do we prevent that from happening again?
Go
ahead, Pascal.
So let me start by saying that this is all about economics and how you manage your funding. We received a lot of money, and I know a lot of funding will be coming down the pike after during this pandemic and before the end of the pandemic. But the way we manage it, years ago, we got a lot of money, like I said, through the BT grant, and we bought a lot of things. We bought masks, bought gloves, but over the years, those things expire, and we need to replenish them. So the funding that we get now, if it doesn't come and continuously come every year, then it makes no sense. You don't fund the pandemic, fund public health, and stop at the middle of the way. It doesn't work that way. All right, you have to consistently funding public health. What we did as a health department was, as soon as we heard that the pandemic, the coronavirus is in Wuhan, China, we went ahead and started purchasing a lot of gloves, a lot of overalls, and hand sanitizers. Like, we knew it was gonna come here. We really knew, because we know it was a plane ride away to the United States. So we became proactive. So by the time people were all gaps in looking out to buy all these PPEs, we had a good stockpile. But it's different in the hospitals because they use them faster than we do. So in a way, it's part of that national planning that those companies that produce PPEs should be situated here in the United States, because what we found at the beginning of the pandemic a year ago is that most of these things come from China, and most of them also come from outside the country. So that becomes a problem because they were hit first, so they'll use the stockpile that they have to take care of their people. So by the time it opened up, we had knee high into the pandemic, and we couldn't get those PPE on time. And that's why hospitals and all those healthcare facilities were improvising with garbage bags and things like that.
Thanks, Pascal. I want to turn to a couple of questions from audience members.
Brenda, did you want to say something? I thought you wanted to pipe in there.
I just wanted to point out that the focus on supplies of PPE was heavily focused on the hospitals, but there was a blind spot for like nursing homes, long-term care facilities, local health departments. As Dr. Nwako said, he ended up going into these nursing homes because DOH didn't have the staff to do it. Where do you get the PPE to keep you safe when you do? So that it's a matter of equitable distribution of these supplies, first of all. And it's also, I think, a matter of transparency in terms of what's going on in certain facilities, because you can't step up and help unless you understand what's going on, for example, in the nursing homes and long-term care facilities. And I think that created a cascade of problems that had very tragic and deadly results.
Can I say one thing on this to your point, Brenda, and it takes us back foundationally to the conversation on equity we've been having. Not every hospital was using garbage bags.
No.
Not every hospital. The reality of what was actually happening is that it was poor hospitals. It was state hospitals. It was state-run nursing facilities. And so it was the inequities. I won't name names, but we know privileged hospitals. They weren't having the same concerns. And so the Mitchell's question is, the investment, it's a broad national issue in urban hospitals that we know serve poor communities. And we can't have a public health conversation or a kind of PPE national strategy conversation without recognizing there's a level of inequality that we've let be okay up till now.
Can I say 3 words?
Sure, more than 3 words too.
Defense Production Act. That should have been in place last January and February, honestly, and we would not have the same issues with inequity and challenges. And that's where the problem starts. And where does public health fit in? There weren't people that were knowledgeable about it in place. There weren't people that were brave enough to say something about it. I don't know. But the Defense Production Act is there for a reason. And if COVID-19 pandemic wasn't the reason to enact it right away, I don't know what is.
And Anna's point, a dramatically inequitable system of distribution.
Absolutely.
And I'm gonna add a word that we have to teach students, because I've had to teach reporters about this throughout the pandemic: federalism. And so we have to remember that public health is the purview of the states. And so this money that Joe Biden is pushing out, there are going to be grants, but some states might not take it. Some states may use it differently. One state's going to use it for data. One state's going to use it for community health workers. One state might give money to the hospitals to increase their preparedness. So we have to remember that, there needs to be a federal, stockpile, but states as well need to think about their individual stockpiles. Because I've heard from far too many people that said, oh, well, you really can't blame Trump because public health is the purview of the states. And I'm like, that's not really how federalism is supposed to work. It's not a blame game. It's a collaboration. But in this presidency, in this past presidency, we lost that, right? Federalism was weaponized in a very different way.
Great. So I've got a couple of questions. We've mentioned a lot of things that went wrong. What went right, and what were the reasons they went right?
Let me start because what went right is because public health departments in New Jersey, at least, and around the country, knew that help weren't coming from any other way. They decided to work as a team. They decided to help themselves out. We were all scattered everywhere, but we talked to each other every day. Hey, what are you doing there? How can you help us over here? What's happening? So we decided to rally around and help ourselves. That's what worked. And that's why so many lives were saved because of that. Yes, I know the State Health Department did the best they can under the circumstances, communicating with us. I have to shout out to the Office of Local Public Health in New Jersey. They did a whole lot of work that I didn't believe that they could be able to handle it. But they organized local health departments from the beginning to tell us what they know, what they didn't know. Yes, there are some failures, a lot of things, but I'm only talking about the positives right now. So let's give it to them. All right. So local health departments rallied around and worked towards the best that we can during this pandemic. We did a lot of lessons learned. And again, the public health workers, the people working at the health department, you have clerks, you have people that know nothing about public health, even though they're part of the public health system, that they work in public health departments. They said, what can we do? How can we help out? They all volunteered, doing the best they can. They helped everybody out. So public health workers worked extra hours to make sure that they got to do contact tracing, case investigation, things like that, before we got help from the State Health Department with contact tracers during the summer. So we got people from, yes, the police department helping us out, from the public works department. We got people from recreation, other departments. They brought their staff in, librarians, people working in the library. So we had that help, and we rallied around, and people were talking to each other, health officers. Hey, what's happening in your neck of the woods? We communicated, and that's the good news. And that's the positive that we had during this pandemic.
The other thing that I would say real quickly that worked is that for the first time on front pages, almost everywhere, we were talking about Black and Brown communities' health conditions. And we didn't start talking about them well, but we started talking about it in a way that had been invisible before then. And in a way that the fight, I think, in part, is to make sure we don't let become invisible again.
So Mitch, in the chat, I'm seeing a question to Pascal about workforce reduction and how that's impacted. So to stay positive, I feel I need to do a shout out here to folks that I know, have known since I worked in Department of Health, and other departments who I work with also. There are people at the local level and at the state of New Jersey, and I'm sure around the country, working tirelessly to ensure the public's health. And I think we need to recognize that. There are people that are lifetime public health workers in the state and in our local county and municipalities that are working tirelessly. And I think we have to recognize, so that's what went right. And they continue to work behind the scenes. They're invisible, as somebody said, but they're doing a lot of things related to COVID-19 directly and other things that they're keeping the work going. And I think we have to recognize that this is the opportunity to try to build up that workforce again, because what often happens, and one of the reasons large turnover is because people burn out. It is very hard work, and it's tirelessly. And I think we have to recognize and do a shout out to people at the state and local level doing this work while we're doing other things.
Thank you for that, Arturo, and not to over intellectualize this, but I think for me, one of the silver linings here, like there's always silver linings, right? I go back to the AIDS epidemic again, or the 1918 epidemic. It's like those those kick-started the ways we thought about public health, right? You know, they thought about the way we get medications activated, the way we had people's voices at the center. You know, Arturo knows because I wrote a paper for him on gay men's health for a journal. Like, nobody recognized gay men's health until AIDS. Like, who are these gay men? I mean, so what I think comes out of this conversation in the 2020 is that many of us have been talking to we're blue in the face, the idea of minority stress and syndemic as conceptual models, the idea that health conditions are synergistic and overlapping and mutually reinforcing. And I think what has emerged in the dialogue of the population of our countries is this notion that you can't separate economics and racism and COVID-19 and these from each other, that these are happening together. And that is a new idea for the country, I think, and an idea that will situate us very well moving forward.
I want to just point out 2 documentaries on health officials who highlight some amazing health officials. One is 54 Days, that is done by the BBC, and that follows, that talks to Halkitis Barbeau, who was in New York, and Sarah Cody, who was in Santa Clara County. And another that was called Outbreak, the First Response. It's streaming on Yahoo. It was done in conjunction with Soledad O'Brien and the de Beaumont Foundation, and it really focuses on the early days. And it focuses on Patty Hayes, who's the director of public health in Seattle, King County. And then I'm going to put a shout out in, if you don't know this group, your life is incomplete. You have to look at the Big Cities Health Coalition. It is, so Jonae Caldoun, who has done amazingly in Michigan, came from Detroit, came from Baltimore. She came through big cities. These, Barbara Ferrer, Patty Hayes, Halkitis Barbeau, these are the real amazing leaders in public health, in governmental public health. And if you are interested in diversity amongst public health leaders, there is no better place than the Big Cities Health Coalition. They are some of the best and brightest public health leaders, many of whom happen to be people of color, but they are the best and brightest regardless. I think Myshika Roberts from Columbus, Ohio is, not to date myself, but she's like the bee's knees. I mean, she is just amazing, and had to stare down Ohio State, dealing with things like football and people coming into her town. And so when you're thinking about, ASTO is great to partner with, but also the Big Cities Health Coalition, because they lead the largest and most urban health departments in the US. So check out those documentaries and check out Big Cities Health Coalition.
Brian, do you have a link that you can put in the chat box for the big cities? I see you have the link for the documentaries there.
I can. And I've also put in links for phrases.org, which helps people communicate with other sectors, the Public Health Communications Collaborative, where we are trying to get messaging out to help. And those are just, all de Beaumont is we're like a public health true value hardware. We have practical tools to help you do your job. Just come on and make use of those tools and tell us what you need so we can be responsive, especially with the Public Health Communications Collaborative. It is there to answer your messaging questions.
But also shout out to de Beaumont, right? Which has been front and center, and doing the good work, right? Like, I remember recording for Brian, why I wear my mask video, 9 months ago, 10 months ago. And that's the kind of face we want public health to have. So Brian, you and your team, thank you.
Appreciate that.
So I have a couple of questions about the disinformation. So how do we deal with when there's a X% of the population that digs their heels in deeper to disinformation on science when given all the facts, in relationship to vaccine hesitancy, vaccine acceptance, and how do we, there's so many conspiracy theories out there. How do we combat that? I got to start with Brenda on this one, because using the media and having valued partnerships in the media is so important. And, Brenda, the work that you've been doing with the school and Perry has been awesome. So I'm going to start with you, and then I'm going to open it up to everybody else.
Thank you. And I think what it boils down to is putting the truth out there. Essentially, you need to, excuse me, you need to make the case for science and for the impact that that has on people. And I think you go out into the community and you bring the community into the conversation, because otherwise it's people talking at you and you want them talking with you. And I think that that's probably key. If you're going to convince people that this is you should believe in vaccines, then you need to bring the people in and meet them where they are and show them why. And I think that as long as media, social media, continues to do that on a regular basis and addresses the conspiracy stuff head on, it's a slow climb, but it's good not to be disrespectful to people. I think that's important. I think that you need to respect them. At the same time, you need to say, all right, let's have a discussion about this, and let me show you why I think that this is a healthier thing to do. That's my answer.
Great, thank you. Anna, jump in, Anna.
So someone wrote in the chat, it's really a great articulation about how do you talk to people who buy into the conspiracies? How do you educate that public? And the point that Brenda was making that I just want to kind of put even a bigger and stronger pin on is made in a book by George Lakoff called Moral Politics. And if you've never heard of the book, I really encourage you to read it, because it makes the argument that when we talk about politics and the notion of respect, it can't be grounded in my way is right and your way is wrong, because the conversation stops at that level, right? There's nothing more to say. You're right, I'm wrong. That's not a conversation, right? But it's, as I said before, all politicians, Republican or Democrat, believe what they're doing is in the interest of the people, right? And that people get, right? And they want well-being. No one's gonna say, I don't care about well-being. We can debate action separately, right? But everyone's gonna say they're invested in well-being. And so to be able to have a conversation from the, if we're both invested in well-being, well, let's talk about what gets in the way. Let's talk about vaccines. Good marriage therapists will tell you, you're not fighting your partner, you're fighting the issue. Put the issue on the table. Talk about the issue. And that's actually really hard to do in America right now. Right? We're not so Democrats and Republicans have become a stand-in for so much. Belief in science is one of those things for folks. And so the ask, if we're going to have real substantive conversations, is being willing to take a step back. Right? They're going to happen at kitchen tables. It's going to happen in churches when we're willing to say, it's a difficult issue, but I care about you. And because I care about you, I want us to have a conversation about how you do well, how I do well, how our community stays safe. And if you both enter with that kind of much more difficult, I'm right, you're wrong, I've got all the science behind me, you're not going to get anywhere.
Yeah, if you're preaching, you're going nowhere.
So, and I want to add a couple of things. One, to the book list for people who want to read Keith Payne's Broken Ladder, which I think also does a really good job of explaining why we behave the way we do when we're under stress and when we're under resourced, and really taking away the blame and looking at the bigger picture, and also brings in some of the politics of why we believe what we do and when we're more apt to believe conspiracies versus not. And Brenda, I think, NJ Spotlight News has been doing a great job of trying to dig in to some of these issues. And, I'm waiting for my contract to work with you guys full time, but.
Hey, how about me?
well, we're going to tag team. We're going to have our own show, Perry.
Okay. Yes.
Also, I've had the opportunity to work with media collaboratives that go into some of these smaller media outlets, these hyper local that are, I had somebody ask me, well, the Hungarian community in New Jersey has a lot of vaccine hesitancy. I wasn't aware of that. I don't speak Hungarian, but really working with those communities at the hyper local level to listen and understand, and to make sure that the voices of public health and the professionals have the opportunity to speak to those communities as well, so that they have access to the information that some of the bigger media outlets also have.
But wait, I think Dr. Silvera was joking, but it wasn't funny, right? It was deadly serious. You should have a show, right? Perry should have a show. If we're going to not be on media platforms, then how will anyone ever, hear about us? And we're not going to get up there and talk about odds ratios and confidence intervals. God help us. We're going to talk about how public health impacts you. It's going to talk about what it means. We have to educate that, we spend so much time, if you think of our world like a fish tank, we spend 99% of our time thinking about the fish while the water in the tank is unclean. And if you don't clean the damn tank, you're all going to die. All the fish die at the end. And that's, we have to be up there taking calls and saying, hey, that's a medical question, we're going to answer that. And so we need to do that. And so I think you're totally on point. You should have a show. And I think all of us should partner on a children's book about public health and epidemiology.
Yep.
Like I am right there for anyone who wants to help with that. If there's a
Yep.
No,
I think Michelle just said just wrote text to me, public health communicators. And I think look, I want to wrap us up here. I think all of us are exhausted after this year, like emotionally, physically, socially, economically, all of it, right? And and I know many of us have been all of us have been on the front lines, and we've been there because we know we have to get the word out. We know. Like when Brenda would email me on a Sunday night, and I was like, oh damn, tomorrow I wasn't gonna wash my hair or take a shower. Now I have to do it. I do it because this is what matters. And so we have to keep this in our minds moving forward to make public health be front and center all the time. And this group of people who have been here this morning are a prime example of why we should be front and center, right? And I appreciate all of you, all you have done for our country, for our state, for our families. And the fight goes on, right? Every single day. And we have to be willing to take the hits, as my friend Anna tells me all the time, until we make things better. So thank you very much on the part of the Rutgers School for Public Health. Mitch, do you want to, and Brenda, say some concluding remarks and anything?
I thought this was such a fascinating discussion. I think we should do this more often. I think, getting the issues out, sorry to all the people who were asking questions that we didn't get to your responses, but we certainly appreciate all that local health, Pascal, and all of our friends from the local health departments who are watching, the extraordinary efforts that you have taken over the last year and all throughout your careers, not just in the last years. And we will work harder to get that information out there and make, public health are the heroes and not just everybody else. So thank you to our panelists, and I'll turn it over to Brenda.
And my thanks too to everybody. And sorry for calling you guys up on Sunday nights and making you take showers, because I do that. I'm a terrible nooch. But the bottom line here is that public health is people. And all of these ideas that we've talked about are fabulous. I don't want them to just die when we hit click leave. Let's make this happen. I think that taking all of these ideas, all of these suggestions, and acting on them is the final mission, if I want to use that word, of this panel. This is a mission, and everybody's got to, as tired as we are and as emotionally drained as we are, we're not even close to a finish line. We have to keep going. Thank you.
Thank you, Brenda. Thank you, friends. Thank you, everybody. We appreciate everything. This has been this could have gone on for 5 hours. I mean, it's amazing, this conversation. Thank you. We'll do it in person at Four Nose with sangria at some point in the near future.
Panelists and moderators, I'm going to take a quick picture. So if everyone can just look at the camera, please.
All right, goodbye, everybody. Thank you for joining us.
Thank you. Have a great weekend, everybody.
Thank you, Perry. Thank you, everybody. That was really good. Appreciate it.